So hi, I'm Jessica, and this is going to be a talk on hypertensive disorders during pregnancy. We're going to talk for like 10 to 15 minutes looking at the hypertensive disorders. You've got notes there if you'd like, and then this magic bag has a lot of equipment inside. And so we're going to brainstorm together about what equipment we would need in the setting of hypertension and preeclampsia, so we'll be able to take the things out. So here are our objectives for class. We're going to look at the different types of hypertensive disorders. We'll talk about the nursing assessments for hypertensive disorders and then identify the equipment that we need. So first, take a look here, see if there's anything you're unfamiliar with. I'm mostly going to focus on preeclampsia, but since we know preeclampsia becomes eclampsia, perhaps we need to look at the two of those. The high blood pressure limit, what do you think that is?
140 over 90.
And then the severe range?
160 over 110.
Perfect, exactly. And then what about the proteinuria limit?
Anything that's not negative.
basically, unless they were doing a 24-hour urine collection, in which case we would actually have numbers. But yeah, anything that's beyond negative. So the pathophysiology of preeclampsia, the blood vessels constrict, which causes vasospasms, and then the blood's trapped in the venous system. That causes the kidneys to absorb sodium and water, and as that happens, we start to see the lab changes that we look for in diagnosing preeclampsia. So although we know this is the pathway, the exact cause is unknown, and it affects all the major organ systems. So we think of preeclampsia in terms of with severe features and without severe features. It used to be mild or severe, but now we actually frame it in terms of features. With severe features may develop very suddenly, and we have to look at those labs to see the full body interaction to see if that's preeclampsia or not. And then eclampsia is a little bit, have you ever seen a patient with eclampsia?
Once.
Yeah. So when there's severe features, the vasospasm causes endothelial damage, and we get dysfunction in the whole system. So cardiovascularly, we are seeing those vasospasms. The pulmonary system, what do you know that we start to see as it advances?
Fluid.
And renal?
Creatinine increase.
Hepatic?
Elevated LFTs.
Yep.
Decreased
Hematologic?
platelets.
Yep.
Seizures. Or headache. I don't know if you could do that in the neuro, seeing spots.
Exactly. All three of those.
Thinking they're already pregnant, so or they just had a baby.
Right.
But it can, I mean, in pregnancy, like IUGR and stuff like that, kind of thing.
Absolutely, absolutely. And then changes in the fetal heart rate because of the interaction with the placenta. Okay, so here's our case study. Our patient comes in, she has elevated pressures, 162 over 94. You identified that would be above the high level. Is that a severe level?
Top numbers.
Exactly, top but not bottom. And we more look at the diastolic in diagnosis. Okay, past medical history. Do you see anything there that makes her a risk factor for hypertensive disorder?
I mean, GDM, I feel like that could affect your vessels.
It can. Yep, absolutely. Treated UTI, not really. What about in her actual 40-year-old G2?
AMA.
Her post-surgical history? Not really. You identified smoking. Late to prenatal care actually is a risk factor. I think it's probably more a correlation than a causation, but still a risk factor to consider. And then medication. So that's good. So we did pick out some risk factors. So what are our standard questions for a patient when we see risk factors and she's coming in with elevated blood pressures?
Headache, spots in the vision, right upper belly pain, swelling, chest pain, dizziness.
Yep, exactly. From head to toe, you got them all. All right, and so what do?
Labs.
We start our PIH order set. So you got all of these. Nice job. Obtain serial BPs. What does that look like?
Typically every 10 to 15 minutes for as long as it takes for the labs to come back.
Yeah, I agree.
Depending on what they're trending.
Why are we checking oxygen saturation?
Because of the fluid overload related to the
So
preeclampsia.
we've got to listen like on initial assessment for coughs and for rails. And then why DTRs and clonus?
They can be hyperreflexic.
Exactly. And what is clonus?
It's when you push the foot back and then it comes back and it beats back at you. That's not, you don't want that.
Nice. Okay. So I repeated our case study up at the top, added what we found on our assessment. I'll give you a second to read through that. So the last part, diagnosed with preeclampsia, what happened? What did we find on assessment?
Severe features.
Okay, so what emergency equipment do we anticipate needing? Here's where we use the bag. Here's where you can pull all the things out to kind of see what we have, and then we're gonna slide things forward that we would start to grab. Let's imagine you're not the primary nurse, because the primary nurse stays with the patient, but you've come in to help me. What things are you gonna pull for me, just based off of this initial assessment, high blood pressure with severe features?
Mag. IV. Well, IV then. Probably mag.
All right, so we got,
And
you pulled out the IV and this fluid, so
Yep.
I'll tell you, I don't have a bag of mag in there.
Yeah.
So what we're gonna do is write out the things that we need that we don't have. So
Okay.
our shopping list.
Uh-huh.
So I'll add mag since you're
Yeah.
still pulling things out.
The doctor may want to give labetalol or hydralazine for that, depending on what it does. I guess we need blood pressure, the Foley, seizure pads, Seizure beds.
Yeah. Do you think we need meds? You said labetalol.
Yeah, I think that's good.
Okay.
It's on our list.
So far the meds were mag,
Yep.
labetalol.
That's really it to start, and then whatever induction agent they're gonna use, because you're gonna deliver them.
So let's move through the next slides and we'll see if we got everything or if we're missing it. So far I feel in good hands. Thank you for being
Yeah.
my second nurse. We're gonna be good to go. So we've got our large bore IV. You identified mag right away. Foley you pulled out. Our hourly assessments.
EKG, yes. Yeah.
All right. So here, let's add that to our shopping list. We'll send somebody to get that for us. Okay, there's a question mark next to 3-lead ECG.
And I think our policy is for the first 4 hours, just because of it being a fluctuating.
Yep. And our regular mag levels, question mark.
Provider discretion.
Exactly. In our policy, it's provider discretion. And so you already identified, we're gonna do induction or C-section or expected management depending on what the labs come back as. You all, PIH labs start a 24-hour urine collection. Right, we didn't mention that, so let's add that to our shopping list. Place in left lateral position, why is that?
Better blood flow.
Yep. All right, assess fetal well-being. What's BMZ?
Betamethasone.
All right, so that's another med that we need. NICU consult.
Just 35 weeks.
Exactly. Ultrasound, let's add that to our list. We're looking for IUGR, abruption, possible Doppler studies, and decrease environmental stimuli. What does that look like?
Kicking everybody out of the room that we can and turning off the lights and telling her to take a nap.
Yes. All right. Now, interventions for preeclampsia. Some patients, if they don't have severe features, might be sent home. So we're going to do all of the education that we can, our ongoing assessment. We talked about the antihypertensive meds, and it's important to talk about the myth that delivery is the only solution. That is the myth, because we know that preeclampsia can occur even in the postpartum period. So we really need to untangle that myth and talk to the patient about, we don't exactly understand the cause. And delivering the baby reduces the risk of 2 people down to just 1 person. So we're really thinking about the baby's well-being and kind of balancing the pros and cons of delivery as far as the reason we need to get the baby delivered. It's not that removal of the placenta will cure preeclampsia. That's a myth. Okay, MAG, I know you're very familiar with that. Do you see anything on here that we need to add to our equipment list?
No, we don't typically keep the calcium gluconate at bedside as long as we have it in there, right?
As long as it's in the Pyxis, but I'll add it up here because it's something we want to think about. And goal serum level has a question mark. Do you know what our goal serum level for MAG is?
5 to 7.
Yeah, 4.8 to 8.4. So that's why we always get called for critical level labs, because they are not going to see it anywhere else. But that's our therapeutic range. All right, these are the things we want to be worried about in terms of MAG toxicity. So is there anything on here that we didn't prepare for?
Nope.
I think we're pretty covered. Why here at the bottom, postpartum, why assess?
It relaxes the muscle.
Exactly. All right. So anything we need to deal with side effects in mom?
We can give her like Zofran and expect the induction to not go as rapidly.
Yes. Patient education on expectations. And anything that we need to have for side effects in the baby?
Peds and NICU at delivery, and just that your babies may not tolerate labor as well.
Okay, great. Let's add peds and NICU to our shopping list, because ideally we'll bring them onto our team. Okay, so problems with serum MAG level. This is just a little bit more information for you on why MAG levels are left up to provider discretion. It's actually not the best way to identify MAG toxicity. Instead, clinical symptoms. So the NURS is the primary way to monitor for maternal toxicity. So we know preeclampsia can develop into eclampsia. Anything that we need here to be ready, prepared, just in case?
I hope you have suction in your room.
That's a good one. We don't have that anywhere, absolutely. And then our nursing management includes all of these steps. Have you seen this before, where seizure lays out the thoughts for management of eclampsia?
No.
For some people, this is good. For other people, it's not necessary. You were able to think through all of these things without it, but that's probably because you are such an experienced nurse. But this might be helpful for some of our new nurses. Okay, so it looks to me like we kind of covered all of the things we would need for assessment of preeclampsia, management of preeclampsia in the antepartum stage, and then possible advancement to seizures and eclampsia. Did you have any questions or think we missed anything?
Nope, I don't think so.
Okay, is there anything left in the bag that we didn't think of? We got them all out.
I think we got them all out.
All right,
Yeah.
those were all just red herrings. Extra things we don't need. All right. All right, well, thank you very much,
Thank you.
Maria. I appreciate it.
Thank you.